Hello, everyone. This is Braswell Dean, again from the Providence Department of Family Medicine. We're back for Codeology Part 5, and we're looking at our coding game review to help you learn how to determine the complexity of medical decision-making and put this in your practice in the fastest, easiest way possible. We've looked at risk. We've looked at data. We've just looked at diagnostic management decision-making, and we saw how easy these were. And we saw how helpful it is to look at this little coding worksheet that we're using to go right through these cases, case by case. So we're going to jump right in now and make it a little bit more clinical and a little bit more exciting for you, as if coding could be exciting. So let's jump right in. We looked last time at risk, data, and diagnostic management decisions in our coding game. Now we're coming to this section, the complexity of medical decision making. This is where we put it all together and make it clinical. So let's jump right in as we were talking. Here we go. We've got a 22-year-old female who comes in complaining of shortness of breath. She has a past medical history of asthma, eczema. She's an established patient here at the practice. And your assessment is a moderate exacerbation of asthma. It's not life-threatening. You don't need to put her in the hospital or anything. She's on albuterol, a steroid MDI, and a steroid cream for the eczema. You treat the asthma appropriately as an outpatient. And you also refill the patient's steroid cream for the eczema. What is the level of medical decision-making for this? So now this is where we kind of put it all together and we allow our worksheet to start working for us. So the 22-year-old shortness of breath with a past medical history of asthma, eczema, established patient with an exacerbation of asthma. First off, the risk is moderate. Why? Because this is an exacerbation of a chronic illness. And we're treating with prescription medication. So this is moderate risk. And as we saw on our teaching tool, and let's jump over to look at the worksheet, anytime we use prescription medication, it's moderate risk. And anytime we have a chronic illness with an exacerbation, a mild exacerbation, it's moderate risk. So we have two things that justify the use of moderate risk. And our example, again, is risk is moderate. Again, exacerbation of a chronic illness or treat with prescription medication. Now look at the data section. How many points do we get? We get 0 because we didn't order anything. We didn't need to. So we are not under any pressure to have to try to order things to generate the code. That's not ethical. So we didn't order anything. Now, let's look at the data of the diagnostic management decision-making. The asthma is a chronic problem that is currently poorly controlled. So we get 2 points for that. And the eczema is a chronic minor problem. That is just a minor problem doing okay. It might be seen by some doctors as an oh, by the way problem. You'd get a point for that, like a minor problem. Maybe if you're a dermatologist, you'd say, no way, that's not a minor problem. That's a chronic problem. Depends on the specialist and your point of view in the practice. If eczema is documented in your chart notes as a significant chronic problem, then it's a significant chronic problem because you document it that way. But if it's just a minor problem and you document it as a minor problem, again, as we've said before, it's a minor problem. So you get 2 points for the asthma and 1 point for the eczema for 3 points. Now, the way the coding tool works, and we'll just take 1 minute to review there, there's 2 points for the asthma being poorly controlled, and depending on how we look at it, 1 point for the eczema being as a minor problem, and that still equals 3. Okay? So let's see how this coding tool then works. And you probably already figured it out by now. It's pretty easy to look at. Risk is moderate. Diagnostic management is 3. And so when we have 2 levels in common that justifies the level, the highest level, we just simply draw a line to moderate. The complexity of medical decision-making for this patient is moderate. So because of that, we let this complexity of medical decision-making, based on the rules of coding, we let that generate the decision for what the code should be as doctors. So we are teaching you to try to always determine medical decision-making first based on the rules of coding, which are easy, and that determines the code. And not only the code, but as we said last time in part 1, the level of documentation required to support this code. Because it doesn't matter if you get the right code, but if you don't document it, you still are not in compliance. So we not only want to generate the code, we want to generate the level of documentation required and understand that. So that's what this little teaching tool can do for you. Okay. So maybe we're feeling pretty good that we're understanding how to calculate MDM maybe. And I know if you're a medical student, maybe this is like, wow, out of my league. Or maybe if you're like an incoming first-year resident, one of our interns, you might think, wow, maybe I can get this, maybe I'm not. But it's never been something maybe you've been taught before. But we all feel this way. We all want to be doctors first. But I think even more so, we all want to be ethical doctors. So this helps maybe give you that feeling that you're that ethical doctor, but also puts it in a language in a simple way you can understand. Let's take diagnostic management for 20. Everybody listen up, because this is so common in primary care. Look at this. A 3-year-old comes in complaining of a painful right ear. Okay? You're going to see this for the rest of your life if you're in primary care. You diagnose right otitis media and you treat with antibiotics. What is the level of medical decision-making for this person, this patient? Let's take a look. How does it code out here? Well, we got a 3-year-old with a painful ear. It looks like otitis media, and it looks like we're going to need to treat with an antibiotic. So the risk is moderate. Why? Because you're using prescription medication. Remember how easy that one was when we first learned risk? Data, 0. Why? Because you didn't do anything. So when you don't do anything, you don't get anything. So that works. There's balance. Diagnostic management, 3. Why? Because it's a new problem, no additional workup is needed. You can make the diagnosis based on your examination and the history that you take. You can make your own assessment. You don't need to order any labs or any x-rays. So this shows you what acute otitis media codes out as. Moderate risk, level 3 diagnostic management decision-making. And again, you have to have the 2 highest levels in common for this to be able to derive the medical decision-making. If this was lower, then the lowest level would, in common, you would have to go down a level to meet the other low level. That would be low there. But as it stands, this is a 99214 with detailed documentation required. There's so many doctors I've seen over the years that don't know this. And undercode because they just don't know this. And this is as simple an example is you can make it. And this is something that you'll see every day. Diagnostic management for 30. A 68-year-old woman comes in for a checkup. Well, I don't know if it's a woman or a man because I didn't say it, but let's say a 68-year-old patient comes in for a checkup. Past medical history, hypertension, diabetes, CHF, COPD, arthritis, obesity, hyperlipidemia, left ventricular hypertrophy. Woo, a lot of stuff, plus a laundry list of medications. This is your primary care specialty here. The chronic medical problem person comes in to see you, and oh yes, I want you to check all my problems, manage all my problems, and you're only going to be able to do it in 15 minutes or so, or maybe 20 minutes max. There you go. That's your challenge, folks. Everything, thank goodness, is stable. And you're just there for checking up and you're reviewing the medicine lists and just making sure things look good and seeing what you have to order. What's the level of medical decision making in this particular case? What do you think? Well, again, patients on prescription medicines and they have greater than or equal to 2 chronic illnesses, automatic moderate risk, easy. This patient, you didn't order anything. Okay, so you get 0. Diagnostic management technically is 8. Okay, why? Because look, all these chronic problems are stable. 8 times 1 is 8. Look at all these problems. It could be 10 problems. So all of these problems are stable, 8 total points, but the highest is 4. So you stop at 4 anyway. After a while, you can stop counting. So this level is a level 4, but it doesn't have anything in common with risk. Risk is not at this level. The only 2 levels here that are in common is this level, this and this, because moderate does have a level in common here because it's covered by this. So this has to drop down to 3 to be in common with moderate level risk. So therefore, the complexity of medical decision making is moderate, and with an established patient, again, another example of the 99214 with detailed documentation required. Even though you got a whole bunch of problems over here, you have to have you have to have 2 common levels in common. So one of these high levels has to drop back to be at the same level in common with the other. And that's the check and the balance on why you have 3 different categories that helps you determine the complexity of medical decision making. It keeps things ethically grounded. You're not making a decision for the 214 over here based on all the bullets you ask in the history and all the bullets you did on your physical exam. You're based on the levels of the rules of coding. So this number is always going to be ethical. It's always going to be baked in to your decision making. And it's always going to be baked into your documentation. No matter how many things you do over here in your note for your history and your physical. Okay, so complexity of medical decision making for 40. Here's an example. We have a 70-year-old female who complains of new, severe back pain. X-rays are ordered to rule out a compression fracture. Past medical history is hypertension and hypothyroid. Okay, so you decide you're going to treat the patient's back pain with a non-steroidal, but, Granny's in your office and, you're not going to address the hypertension or hypothyroid this visit, because she's in such severe back pain. It just doesn't make any sense to say, hey, Granny, I know you're writhing in pain on the table here. Let me check your thyroid. Hold still. Let me, let's check on that. And, let's check on your blood pressure. We always do check it, but we're not really going to, I want you to hold still and let's talk a little bit about blood pressure today. Nope, that doesn't really fit, does it? So this is illustrating a point that you can have things in your past medical history and you can look at them and note them, but as far as what needs to be treated, you as the doctor can decide. If you think these need to be treated, let's say your blood pressure was 200, then you could put that. But you as the doctor ethically can decide what needs to be treated. And if there's new severe back pain, you may say, no, what? I'm just going to focus on the back pain today. And that's what this doctor did. And this is how this visit encounter codes out. Risk is moderate. Patients on prescription medication, because you prescribe something for the new severe back pain. Data is 1 point because you ordered the x-ray. Diagnostic management is 4 points. Why? Because there is a new problem and it needs workup. Boom, 4 points. That's Granny's back pain. Now, you don't even if you did address the hypertension, hypothyroid, the counting stops at 4 because it's the new problem needing workup. So you can address the hypertension and hypothyroid if you want, but you're not obligated to. You're only obligated to address what you want. Just because they're in the past medical history doesn't mean you have to automatically pull them into chief complaint. You're pulling into chief complaint what you need to treat today. So this is an example of, again, 4 points being super duper high because this is a new problem needing a workup, but it doesn't have anything in common with the moderate level risk because you're using prescription medication. And again, we're making the point that one of the highest things you can be compensated for in primary care, or whether you're a consultant or whatever, is this new problem. When somebody comes in with a new problem needing additional workup, you know that's automatically 4. And that can be pretty high. And if they're at high risk, this is the highest of all. A new problem needing additional workup that's unstable, the patient's unstable, that's a 99215. But in this scenario, you've got 4 total points, and it doesn't matter if there's a whole bunch of other issues, or maybe it's 2 new problems needing additional workup. It all stops at 4 anyway. So this drops back to this level. Moderate, level 3 is moderate in 99214. And you may be noticing that a lot of these are 214s, and the reason I'm emphasizing this is because this is probably one of the easiest missed things. So many questions about all these issues, and the fact that so many times, so many doctors are not used to giving themselves credit for the work that they do. And that so many doctors are seeing so many patients with chronic problems, new problems needing workup. This is where your practice in general resides. Let's jump on to medical decision making for 50. Here we have a 65-year-old complains of shortness of breath, past medical history of hypertensive cardiomyopathy with congestive heart failure and hypertension. The exam is consistent with an acute congestive heart failure exacerbation with a blood pressure of 162/96. You decide to hospitalize this patient for an acute exacerbation of hypertensive cardiomyopathy with congestive heart failure. However, interestingly enough, this is a non-life-threatening presentation. You don't think she's a threat to life, but you do think she needs to be in the hospital. Interesting. What's the level? Is the risk high or is it moderate? And I put this in there because of so many times this question comes up too. As a matter of fact, this whole tutorial is based on all the questions people ask year after year. Okay, notice that not every single person in the hospital or being admitted to the hospital is having that threat to life. Okay? And I've often given the example of a heart attack, and I usually give that in the risk section, and I guess I didn't remember it until this section, but let's talk about risk in another way. If you see this patient in the office and you think that congestive heart failure might have been due to a heart attack, let's say it was due to a heart attack. They're tachycardic, they're tachypnic, they're short of breath, their oxygen, their pulse ox is really low. And you're thinking that's a threat to life, you're thinking they're having a heart attack, well then the risk is high because you said it was. But let's say once they're in the emergency room and the patient gets diuresed, they're feeling better, they get oxygen, their heart rate comes down, tachypnea comes down, and maybe they had a little N-STEMI or something. But they're not in failure anymore. They still have the N-STEMI. Or maybe it was just a mild heart attack. Is the patient still high risk? I mean, technically they still have the heart attack, but technically to the coders, it's not high risk anymore. Why? Because you said it's not high risk if the patient's improving. So remember, this risk is always a slice in time when you see the patient. And not everybody in the hospital is high risk. So in this example, this patient is being admitted for an exacerbation of the cardiomyopathy, hypertension, hypertensive cardiomyopathy with congestive heart failure. You could call it an exacerbation of congestive heart failure. But it is an exacerbation of a chronic disease, but it's non-life-threatening because we say it's non-life-threatening. It's non-life-threatening because we haven't documented that it is life-threatening. And if we don't document that it is life-threatening to the coders, it's non-life-threatening. If it was non-life-threatening, let's hope by the end of the day it won't be life-threatening, or let's hope by tomorrow it's not life-threatening after some diuretics. But in this particular case, it's moderate risk because, again, we say it's moderate risk, and we say it is an exacerbation of a chronic disease. And the patient also has 2 or more chronic diseases. And also in the history, we'll go back to the history. I didn't really put in the history that the patient might have been on prescription medication, but if the patient was on prescription medication, again, another criteria would have been met for moderate risk. Data, they're being admitted for hypertension. We didn't order anything through our office. We were going to let the ER do that. So remember, the slice in time where we render the service is what determines our complexity of medical decision making when we see the patient. Okay? Now, let's look at the diagnostic management. Again, 2 chronic diseases, CHF, cardiomyopathy, poor control. So this is not a new problem. This is not 4 points because of a new problem needing a workup. These are established problems. The hypertensive cardiomyopathy, the congestive heart failure, both are poorly controlled. We can make the argument they're both poorly controlled. Why? Because it's going to be in our assessment. So we get ourselves 4 points there. But again, I don't have 2 levels of this high in common. Therefore, this level needs to move down to this level so that these 2 levels now have 2 levels in common. Moderate risk, 99214. Detailed documentation is required for this section as well. How does it look on the form? 2 problems, poorly controlled. And again, chronic illness with exacerbation, or 2 or more stable, or 2 or more chronic illnesses, right there. That's how this looks. So we'll stop here at complexity of medical decision making, and in one more section, we're going to go through some bonus cases to drive home these points on how to get your confidence up in calculating complexity of medical decision making. So we'll see you in the next part. Take care.